Hello everyone and welcome to a new session on clinical pharmacology and drug therapy. Today we are going to speak about rheumatoid arthritis. I am Dr. Hassan, Dr. Khalid Hassan, Professor of Clinical Pharmacology and Drug Therapy. Regarding rheumatoid arthritis, today for our topics, we are going to discuss the definition of rheumatoid arthritis and the etiology of rheumatoid arthritis. We are going to discuss the pathophysiology, the clinical symptoms, the clinical signs and symptoms, in other words. Also, we are going to discuss the diagnosis, how we diagnose the rheumatoid arthritis briefly, but we are going to spend more time about management of rheumatoid arthritis regarding non-pharmacological approach and pharmacological approach. And we have other maybe management could be related like physical therapy or surgery can be one of these methods of maybe management or treatment of rheumatoid arthritis. Okay, let's get started. Okay, so regarding rheumatoid arthritis, as we discussed in the brief introduction, rheumatoid arthritis considered like chronic systemic inflammatory disease, and this affects the joints and affect both joints, in, for example, in left and right hand, and the left and right hip. This is what we mean in the symmetrical joints. And this also is not only involve joints, the rheumatoid arthritis also affect extra articular involvement. That means we have tissues not related to the joint may be affected there. So the patient come to the clinic may suffer from rheumatoid nodule, vasculitis, eye inflammation, neurological dysfunction, cardiopulmonary disease, lymphoadenopathy, and splenomegaly, which mean the enlargement of the spleen. Okay, so you can see here we have joint involvement. Here we have arthritis, we have inflammation in the joints, in addition to the extra articular tissue involved in this inflammation process, vasculitis, eye inflammation, neurological disorder. Okay, so this chronic, we speak about chronic inflammation here, and the tissue will be maybe affected there. The most important tissue will be the joint. The joint capsule will be affected, and this will lead to the proliferation of the joint tissues, and this will lead to the inflamed and proliferation synovium, lead to the formation of pannus, is kind of chronic inflammation in the blood vessels that provide blood flow to the joint. This pannus later on invade the cartilage, invade the bone surface. Pannus invade the cartilage, invade the bone surface, and cause erosion in the bone and cartilage. And the end will be destruction of the joints. So you can see here the chronic inflammation and other process talking about immune response, like immune dysfunction response. So you can see here the process for the rheumatoid arthritis kind of chronic inflammation lead to the formation of pannus, like chronic inflammation in blood vessels, and this pannus will invade cartilage, invade bone surface, and cause erosion in the bone, erosion in the cartilage, lead to the destruction of the bone. I click on the link available on the slide, and it takes me to this website regarding synovial joint, and this is represent the healthy. Let me minimize it a little bit. This represent the healthy joints. Here you can see the bone in both sides, and upper and lower end. Then we have the cartilage. You can see the articular cartilage here. Then we have synovial membrane. This is synovial membrane, and then we have articular capsules, and we have the joint cavity. Inside the joint cavity, we have synovial fluid. So you can see here the bone, healthy bone with a density, with a synovial smooth surface between the upper and lower end of the bone. This is a healthy bone. It's very important to remember this part. Okay, this is the first one here, and the second one I will click on the YouTube link, and then we can go with you about maybe talking about what happened on the bone in one slide, only less than 30 seconds. I'm not going to bring any information from that part, but I maybe give a credit for this website, this YouTube, because they brought animation, very important, and clarification for everyone to understand. Okay, in this slide here from the YouTube channel, and I credit to the Nucleus Medical, you can see here the inflammation in the joint and immune reaction. Okay, the second part will be the white blood cells attack the joint tissues and cells. Okay, the white blood cells release chemical called cytokines. Okay, you can see here the synovial membrane start involved in inflammation. This will lead to the involved blood vessels, and this blood vessels, inflammation of blood vessels called Janus. If I go to my slide here, you can see the Janus here. The Janus invade the cartilage and the bone surface and cause erosion and destruction of the joint, and we are going to see that on the slide. Here you can see the Janus invade the cartilage, invade the bone. So this invasion causes inflammation and immune response, and you can see the swelling of the joints. And here you can see the joint, the space will become narrow, and the both edge of the bone will be approach each other, and without any treatment, here you have the ankylosis. Okay, you can see the ankylosis here as kind of a fusion, close connection with both edge of the joints, and chronic inflammation. Okay, so again, this explains the mechanism of action, how the inflammation starts by white blood cells attacking the joint. Okay, regarding a little bit of details here, as you can see, in rheumatoid arthritis, our system, our body no longer differentiate between self and non-self tissues, and they start attacking the synovial and connective tissues, and this we call this one autoimmune response or autoimmune disease. And we have several factors maybe involved in this chronic inflammatory process. Could be genetic factor, could be environmental factors such as smoking, pulmonary disease, infectious disease, E. coli, Epstein-Barr viruses. All these may be considered like other factors to predispose to the rheumatoid arthritis. Rheumatoid arthritis, as we discussed in the beginning and in the videos, is kind of invasion of synovial joint, synovium and joint by the leukocytes. So the white blood cells attack the joints and cause synovitis, cause cartilage destruction, cause bone connection. We call this one ankylosing, and fusion of tissue destruction. So you can see here we have inflammation, synovitis, we have destruction of cartilage, and we have bone and connective tissue destruction. Okay, so regarding immune and inflammatory mechanism of in rheumatoid arthritis. Okay, as we discussed in the beginning, we have two major components involved in rheumatoid arthritis. Number one, we have immune mechanism, and number two, we have inflammatory mechanism involved in rheumatoid arthritis. Immunoglobulin and complement system. You can see here when you have rheumatoid arthritis, the immunoglobulin activate the complement system, and this will lead to the stimulation of T cells and B cells production. Also, this will involve in the activation of cytokines, especially you talk about tumor necrosis factor alpha, and we have interleukin, especially we have three main interleukin involved in rheumatoid arthritis: interleukin 1, interleukin 6, and interleukin 16. So this interleukins will be target for our treatment. So for this reason here, we need to be familiar and remember which pathophysiological cells will be involved in rheumatoid arthritis. Here we have tumor necrosis factor, could be target for our treatment, interleukin 1, interleukin 6, interleukin 17, T cells and B cells All these will be a target for our treatment. What else here? So they found also macrophage will be involved, and osteoclast will be involved, activated, fibroblast will be activated, chondrocytes will be activated. So we have so many cells involved in this inflammation and immune mechanism of rheumatoid arthritis. Another process will be involved a kind of enzyme called Janus kinase enzyme. It's kind of tyrosine kinase involved in the cytokine production, also immunoglobulin regulation. So we have this Janus kinase involved in the tyrosine kinase activation of cytokine and immunoglobulin. Also, when we have this inflammation, this will lead to the release of other inflammatory factors such as histamine, kinin, and prostaglandin. Here, kind of active learning. We have the like multiple choice short question. Rheumatoid arthritis is a disease caused by abnormality. Which of the following system in our body? Which system will be involved? Abnormality, nervous system. Talk about nervous system, immune system, digestive system, or respiratory system. The answer, I would like to know your answer in the description box below, in the discussion, and it's open for everyone to answer this question here. Which abnormality system will be involved in the rheumatoid arthritis? Okay, we are going to present some images regarding the rheumatoid arthritis after discussing the clinical symptoms and signs. Okay, what happened here with rheumatoid arthritis? We have a clinical presentation briefly, and again diagnosis. We have two parts here. So we are going to discuss the clinical presentation and the diagnosis. Regarding clinical presentation, in this column here, the patient may suffer from morning stiffness that lasts for more than 30 minutes. Number one. The patient suffers from joint deformity, and the patient suffers from tenderness, warmth, and swelling of in hand and feet. And normally this one symmetrical joint involved in this process here in both hand, right and left. It's not only in one hand, not asymmetrical. It's like symmetrical joint will be involved. Patients suffer from joint symptoms in addition to the systemic symptoms, for example. So you can see the patient come to the clinic suffer from fatigue, weakness, fever, loss of appetite, muscle pain, joint pain. So you can see here we have some other factor maybe involved. It's not only arthritis. We have arthritis, morning stiffness, more than 30 minutes, joint deformity, and the patients are from general symptoms, systemic symptoms such as fatigue, weakness, fever, loss of appetite, and muscle and joint pain. How to confirm the diagnosis? In addition to the clinical presentation, we look on the laboratory tests. For example, here we have rheumatoid arthritis factor, rheumatoid factors, and this, when you do this one, when you implement the rheumatoid factor RF, this will be positive in 60 to 70% of the case. Another blood test we can do it to the patient is anti-cyclic citrullinated peptide, anti-CCP antibody. This will be highly specific result. Highly specific results. Like when you do this test, it's like 90 to 95%. This will be positive. So highly positive test for the rheumatoid arthritis will be anti-CCP. And this maybe lead to diagnosis 90-95%. So this one considered like highly specific maybe blood test for the patient. Also we can see the ASR is high, CRB also elevated. Patient may come to the clinic from normocytic, normochromic anemia, thrombocytopenia. What we mean with the thrombocytopenia, what we mean here decrease platelet number. Okay, decrease number of platelet and the blood cells, thrombocytopenia and anemia. Okay, through the Google images here, I'm not going to focus on any website. In general, you can see here what we have for the rheumatoid arthritis. For example, if you start here, the rheumatoid arthritis mainly affect the small joint on the hands and feet, And you can see it here again. We have it there, and here we have the nodule, rheumatoid nodule there. For the also what happened here, eye could be involved in the rheumatoid arthritis. Rheumatoid arthritis does AI affect, does RA rheumatoid arthritis affect the eye? Yes, and you can see it's addressed in several websites. You can see it's here involved in the eye. We have involvement here. The patient may suffer from dry eye, uveitis, cataract, glaucoma. All these may be related. So eye will be involved in the rheumatoid arthritis because we have systemic symptoms. Again, moving to the what else here? The skin. Yes, the skin will be involved. You can see here a type of dermatitis here, or kind of inflammation on the skin surface, and the patients are from skin inflammation. You can see it. And the last one here, we talk about nodule. And if you scroll down a little bit, you can see here the rheumatoid nodule here, and another one here. So this is all these considered like clinical symptoms of rheumatoid arthritis. And the last symptoms or syndrome associated with rheumatoid arthritis called Filti syndrome. And for the Filti syndrome stand for Santa. And what that means when you talk about Filti syndrome, if you click on the slide here, for example, for the Santa, you can see it here, and you can see it here in another slide here. Filti syndrome associated with the splenomegaly, anemia, neutropenia, thrombocytopenia, arthritis, stand for an abbreviation for Santa, for example here. We have it here again. We have it like what we have: splenomegaly, anemia, neutropenia, thrombocytopenia, and arthritis. Okay. So from the image here, you can see the rheumatoid arthritis involve joints, involve eye, involve skin, inflammation, eye inflammation. We have Filti syndrome. So we have several maybe symptoms. Could be related to the joint, could be related to the extra articular tissues. Okay, the maybe brief question, true or false question. Rheumatoid arthritis only affects only bones and cartilage, true or false? Okay, we can maybe leave maybe your response in the description box. Here another question: which of the following laboratory test has high specificity? So we ask about high specificity in detecting rheumatoid arthritis, especially during early disease. Rheumatoid factor, anti-nuclear antibody, anti-histone antibody, or anti-cyclic citrullinated peptide. So we have four options: A, B, C, D. What is the most popular maybe answer for this question? Which of the following laboratory test has high specificity for detecting rheumatoid arthritis? Okay, let us know your correct answer or your answer for this question in the description box. Okay, moving to the management of the rheumatoid arthritis. As you can see here, we start with the non-pharmacological therapy. Include rest, include occupational therapy, physical therapy, weight reduction. Sometimes we go to the surgery as last approach. So rest will be benefit the joints. That's important here. Rest. We advise patients for the rest because they found rest relief stress on the inflamed tissue. Rest will be lead to the prevent joint destruction and relieve pain. This is great. But on the other hand, they found excessive rest lead to the immobility and decreased range of motion, and the excessive rest will lead to the muscle atrophy and contractions. So we recommend to go with moderate rest, not like excessive rest, in order to relieve the stress on the joint, to decrease inflammation and destruction, relieve pain, and avoid any complication of extra or excessive rest. Again, for the occupational and physical therapy, I will leave this one to the physical therapy specialist, physical therapy students, physical therapy specialist to discuss that, how to approach the patient with the rheumatoid arthritis. If the patients are from obesity, it's highly recommended to decrease weight and maintain ideal body mass index. Surgery will be the last resort for the patient with the rheumatoid arthritis. Now moving to the pharmacological treatment. Medication used in the treatment of rheumatoid arthritis. The mainstay or the main group of medication used for rheumatoid arthritis called DMARDs. So normally we use DMARD, and another group called non-DMARD. So the main group of medication will be DMARD, and we have some maybe additional treatment could be added as a non-DMARD treatment. Okay, so regarding DMARDs, DMARDs stand for disease modifying anti-rheumatic disease modifying anti-rheumatic drugs. So disease modifying anti-rheumatic drugs. This group of medication considered like cornerstone of the cornerstone of the rheumatoid arthritis, drug of choice. We need to remember that. So the drug of choice when you diagnose patient with rheumatoid arthritis, start using DMARD. So DMARD, drug of choice. Start using this group of medication as early as possible. Start early for better outcome and reduce mortality for rheumatoid arthritis. The effect of this medication, a great effect. They said this medication slow progression of the disease. This medication delay onset effect from weeks to months. And what that mean, when you diagnose the patient with rheumatoid arthritis and you prescribe the medication will take weeks to months to see the effect, the positive effect. So please remember here, we need like this one need time, slow onset of action. We need time to see the effect of DMARD on the patient. Okay, moving to the non-DMARDs. Non-DMARDs, we have two main groups discussed in details in other lectures and other YouTube. We have NSAID, discovered already in the other record. I refer you to that slide. Then we have the corticosteroids. So we have for non-DMARD two main group of medication. NSAID, that's perfect for the relief pain, improve symptoms, rapid symptom improvement. If you need rapid symptom improvement, go with the NSAID. Ibuprofen, celecoxib, naproxen, piroxicam, list of medication. But there's no effect on the disease progression. As you can see here, the DMARD slow disease progression. What about non-DMARD? There's no effect on the disease progression. Okay, the same apply for the corticosteroid. Corticosteroid present quick symptoms relief. However, we have to be careful when we use corticosteroid for long-term use. This will associated with the complication risk. For example, this will lead to the osteoporosis. Okay, this will lead to the osteoporosis. This will lead to the risk of hypertension. And this will lead to the risk of diabetes mellitus. And other, for example, we have cataract, for example, here. Okay, as you can see again in the slide, we are going to discuss two main groups. The first group will be DMARD. So the first group we are going to discuss with you DMARD. And the second group will be non-DMARD, and it's already covered like NSAID and the glucocorticosteroids. Okay, moving to the DMARDs, here is this is maybe the core treatment of rheumatoid arthritis, the major treatment of rheumatoid arthritis, and again the DMARD stand for disease modifying anti-rheumatic drugs. Disease modifying anti-rheumatic drugs. We have two main maybe category for DMARD. We need to remember we have biological factors, biological agent, then we have non-biological agent. We have another name for non-biological agent. We call this one conventional therapy. Other textbook called like traditional therapy DMARD. So DMARD should be non-biological, biological. Non-biological, another name conventional, traditional DMARDs. Okay, I will start with maybe saying the name of the DMARD non-biological and consider like first line treatment, methotrexate. Okay, then we have sulfasalazine. Then we have hydroxychloroquine, leflunomide. So we have four main medication very popular in the practice. Methotrexate, the number one, methotrexate. Number two, leflunomide, Ariva. And then we have hydroxychloroquine. Then we have sulfasalazine, four main medication. The same for non-biological conventional, we have a group of medication less frequently used because of the toxicity of this group of medication is effective in the but compared with what we have there is less efficacy. Okay, so what we have here, you can see here we have a list of medication, less efficacy and more toxic, and therefore we don't use it very often in the practice. The most popular medication used in practice, methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, less used, less frequently used as a thioprine. Then we have the benzylamine, gold salts, we have cyclosporin, we have cyclophosphamide. All these medication maybe present some efficacy, some effect on the treatment, but due to the toxicity, side effect is not popular in a clinical use. Moving to the biological DMARDs. Biological DMARDs here, we have TNF-alpha inhibitors, the first group. The second group, we have interleukin inhibitors. The third one will be medication target the B cells and T cells. So we have four main groups: TNF-alpha, interleukin inhibitor, B cells, T cells. And other textbook talking about biological factor TNF-alpha and non-TNF-alpha. I will start with the TNF-alpha. So biological DMARD, tumor necrosis inhibitor factors inhibitor. We have adalimumab, Humira. We have etanercept, Enbrel. We have infliximab, Remicade, Cetrulizumab, Golimumab, so Simboni. So you can see here that TNF-alpha, tumor necrosis factor alpha inhibitor, biological factors, I will repeat it: adalimumab, etanercept, infliximab, Cetrulizumab, and you can see MAB here stands for monoclonal antibodies. Okay, interleukin inhibitor, we have two main medication. The first medication we have anakinra. Anakinra mainly inhibit interleukin 1 and start with A. Remember that anakinra inhibit interleukin 1. Then we have tocilizumab. Tocilizumab inhibit interleukin 6. Okay, moving to the last group here, B cells and T cells target agent. We have this group of medication used for rheumatoid arthritis: rituximab, rituximab, and then we have abatacept. So rituximab mainly target the B cells, rituximab targeting the B cells, and abatacept mainly targeted the T cells, inhibit T cell activation. So we need to be familiar with this diagram here when you approach the patient. Okay, we can create several questions from this slide here. Which of the following non-biological DMARDs? Which of the following considered like conventional DMARD? Which of the following considered like biological factors? Which of the following biological factors belong to the tumor necrosis factor alpha? Which of these biological factors belong to the interleukin inhibitor? What is anakinra? What is rituximab? So we can answer the question from the slide in different ways. We need you to be familiar with the name here in the slide. I will repeat the name for this medication for each group as a reminder. I will start with the first group here, non-biological. I will go back. Non-biological DMARD, we have methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. Less frequently used non-biological factors due to the less efficacy and greater toxicity as thioprin, the benzylamine, gold salt, cyclosporin, cyclophosphamide. Done. Moving to the biological DMARDs, we have TNF-alpha inhibitor. TNF-alpha inhibitor here, tumor necrosis, adalimumab, etanercept, infliximab, cetrulizumab, golimumab. Okay, medication for rheumatoid arthritis belong to the interleukin inhibitors. We have anakinra, and then we have tocilizumab. Beta medication used for rheumatoid arthritis by inhibit B cells. We have rituximab. Inhibit T cells. We have abatacept. Okay, due to the importance of the DMARDs, disease-modifying rheumatic drugs, due to the importance of this group of medication, I'm going to repeat this list here because we need to be familiar with these names here. And I found a student struggling with the remembering name of medication. I will repeat this medication. The first things we need to remember for the DMARDs, we have non-biological DMARDs, or another name, conventional therapy or traditional therapy. And with the first one on the list, we have methotrexate. As you can see here, we have methotrexate. The first one, we have methotrexate. Then we have leflunomide. Then we have hydroxychloroquine. Then another one will be sulfasalazine. This group of medication considered the most popular medication in the practice. When you see patient in the clinic, this is the most important medication. We have less frequently used medication due to the lack of efficacy and greater toxicity, and this include the azathioprine, dibenzylamine, gold salts, cyclosporin, and cyclophosphamide. Regarding biological factors or biological DMARD, we have TNF-alpha inhibitor. Let me change the pen here to the pen and make it like a red color here. Okay, we have TNF-alpha inhibitor, and we have interleukin inhibitor. Then we have beta cell inactivation and T cell inactivation. I will start with the TNF-alpha inhibitor. We have adalimumab. Then we have Humira, we have etanercept, Enbrel, we have infliximab, Remicade, Satralizumab, and Golimumab, Simboni. Regarding the interleukin inhibitor, we have interleukin 1, we have anakinra, inhibit interleukin 1, then we have tocilizumab, inhibit interleukin, Actemra, inhibit interleukin 6. Okay, moving to the B cell inactivation, we have rituximab inactivate or inhibit B cells. Then we have abatacept inhibit the T cells. Okay, someone may compare or ask about differences between biological and non-biological DMARD. What are the differences here? As you can see here, biological DMARDs, like when you speak about biological DMARD, this agent, this group of medication targets specific immune pathway. For example, targeted cytokine, target T cells, target B cells, or target some maybe other molecules in the inflammation process. And this group of medication mainly given injection or infusion. So you can see here the medication we speak about target the tumor necrosis factor, for example, T cells, B cells, and so on. Non-biological factors here talk about methotrexate, leflunomide, Areva. So you can see here act broadly on the immune system. It's not targeted a specific type of immune system. Mostly given orally. So for example, methotrexate considered like first-line therapy, and this is prescribed orally. Okay. Okay, we start with what is the first-line therapy for rheumatoid arthritis. The first-line therapy for rheumatoid arthritis will be non-biological DMARDs. We need to remember that. Non-biological DMARD, first-line therapy for rheumatoid arthritis, we start with a methotrexate or leflunomide, or we go with a combination therapy. So this is the first-line therapy. So the first-line therapy could be monotherapy, one of these medication, methotrexate, or leflunomide, or combination therapy. Okay, so example for methotrexate, you can see the highlight bold here, preferred treatment for the rheumatoid arthritis and superior result for long-term outcome. Combination therapy more effective than monotherapy. When the monotherapy is inadequate, we move to the combination therapy. What happened with the leflunomide Areva? They said leflunomide shows similar long-term efficacy to the methotrexate. So you can start with the methotrexate. If you find response, that's fine. If not, you can switch the patient to leflunomide. If there is no response from the monotherapy, we can move the patient on the combination therapy between two treatments like methotrexate and Areva, for example, or leflunomide. Okay, regarding biological agents here, as we discussed that, we have TNF-alpha. I will go back. We have TNF-alpha. Okay, biological factor for rheumatoid arthritis. We have TNF-alpha. Then we have non-TNF-alpha. Non-TNF-alpha, we have two groups of medication. We have group that target interleukin, and another group target T cells and B cells. Okay, this medication we use when the patient failed to the treatment response, failed response to the other treatment. For example, you prescribe methotrexate, you prescribe leflunomide, and the patient failed to respond to this medication. This is the alternative for the patient. According to the American College of Rheumatology, ACR, American College of Rheumatology, they endorse the using anti-TNF alpha biological. Okay, anti-TNF alpha biological, they endorse, they recommend use it in the early high activity of rheumatoid arthritis. So the first candidate for the TNF alpha, high activity of rheumatoid arthritis. Number two, we have poor prognostic factors. So we have two maybe conditions to give us license to use TNF alpha inhibitors. Number one, early high activity rheumatoid arthritis, and number two, poor prognostic factors. Example for poor prognostic factors, we have the patients from the patient come to the clinic suffer from functional limitation, extra articular disease such as rheumatoid nodule, vasculitis. The blood test reveal positive RF or positive ACPA or AACP, bone erosions, bone infusion. So all these consider like poor prognostic. So in this case, we are going to prescribe, or they recommend ACR. ACR recommend to use TNF alpha. So we have practice question here. Which the following agent recommends as initial treatment for rheumatoid arthritis patient? We asking about initial treatment. NSAID, leflunomide, methotrexate, cortisone, or sulfonamide. So which one the first line therapy, the initial therapy when you diagnose patient with rheumatoid arthritis? Let me know your answer in the description box. Okay, so speaking about methotrexate, how the methotrexate work, mechanism of action, MOA. They found methotrexate inhibit enzyme called dihydrofolic reductase, and this enzyme responsible for conversion of dihydrofolate to the tetrahydrofolate, and by this that mean that methotrexate interfere with the purine and thymidylate synthesis, and this will lead to the disrupt of DNA synthesis, and in this case methotrexate interfere with the repair and cell replication. So you can see here methotrexate work as anti-cancer drugs. At the same time, methotrexate present anti-inflammatory effect. Methotrexate present immune suppression effect. So all these related to the effect of methotrexate. Number one, we need to remember the main step for the methotrexate. Methotrexate inhibit dihydrofolic acid reductase. Number one, prevent conversion dihydrofolate to the tetrahydrofolate, and this will lead to the interfere with the synthesis of purine and thymidylate, and the end result will be disruption of DNA that responsible for repair and cell replication, and this will lead to the cell death. Okay, so now we understand the mechanism of action here. Okay, through the Google images here, as you can see here, I type there methotrexate mechanism of action. Everyone can maybe serve the website Google image, and you can see here we have methotrexate, and the methotrexate MTX here inhibit enzyme called dihydrofolate reductase, and this dihydrofolate reductase is responsible for conversion of dihydrofolate to the tetrahydrofolate. If I click on this image here a little bit, they give us some more information. I scroll down to the image, should be somewhere here. Okay, and this one what you need here. If you click on this one, you can see here the methotrexate effect. Methotrexate enter the cell, inhibit dihydrofolate reductase, prevent conversion dihydrofolate to the tetrahydrofolate, and this will lead to the inhibit of thymidylate and inhibit folic acid synthesis. Okay, we understand now how the methotrexate work. Moving to the adverse effect of the methotrexate may cause, when you prescribe it to your patient, you need to monitor your patient due to the possibility of serious side effect. Methotrexate may cause pulmonary fibrosis. Methotrexate may cause hepatotoxicity. Methotrexate may cause bone marrow suppression, and the patient come to the clinic suffer from pancytopenia like leukopenia, anemia, and thrombocytopenia, mean decreased number of white blood cells here. Stomatitis, GI ulceration, alopecia. So all these related to the methotrexate. Our repeated serious side effects coming associated with the methotrexate. We have pulmonary fibrosis, we have hepatotoxicity, bone marrow suppression, decreased white blood cells, anemia, decreased platelets, thrombocytopenia, stomatitis, ulceration, GI ulceration, alopecia. Okay, so how we can manage the situation here? What happened here? This medication here inhibit formation and synthesis of folic acid. We know that folic acid is important for the blood cells function, and deficiency of folic acid will lead to the anemia. So in order to prevent the anemia or prevent any of these side effects, for example, and the most important maybe complication, anemia, we recommend to prescribe folic acid or another medication called leucovorin. So leucovorin or folic acid supplementation will be important during treatment with the methotrexate to prevent any these important side effects, focusing on the anemia here, because folic acid is important for the red blood cells formation and hemoglobin. This is an important thing. So the rescue therapy for the methotrexate will be folic acid or leucovorin, and we have it in the image, in the previous image before. Okay, as you can see here, that we can prescribe leucovorin as rescue therapy for the patients from folic acid deficiency. Okay, leucovorin will be the rescue therapy. Okay, can we use methotrexate during pregnancy? They said no, because methotrexate considered like teratogenic agent. We don't use it during pregnancy. It's not allowed to use during pregnancy. Anti-cancer drugs. Contraindication, okay, we don't use it during pregnancy or lactation. If the patients are from chronic liver disease, yes, because this medication causes hepatotoxicity. We don't prefer to use this medication in patients with hepatotoxicity. If the patients are from immunodeficiency, we don't recommend to use it. What else? They said if the patients are from Brewer or like peritoneal effusions, if the patients are from lung disease or tissue lung disease, this medication causes pulmonary fibrosis. We don't recommend to use methotrexate. If the patients are from leukopenia, thrombocytopenia, it's not allowed to use methotrexate. If the patients are from blood disorder, if the patients are from creatine clearance less than 40 milliliter per minute here, we don't recommend to use methotrexate. So all these like contraindicated, caution, warning for the patient. Our repeated here should be number one, pregnancy and lactation, liver disease, creatine clearance less than 40, blood disorder, thrombocytopenia, leukopenia, pulmonary disease, liver disease, immunosufficiency. Methotrexate for the rheumatoid arthritis, we use methotrexate 2.5 milligram, and this will maximize to the 7.5 milligram. That means we start with the one tablet, and sometimes we can take 3 tablets every week, so one tablet per week. However, when we need to use the methotrexate as anti-cancer therapy, roughly we start using the high doses of methotrexate 30 milligram per day. And you can see here, when we have different dose, we have different indication. So low dose, weekly use, we use it for rheumatoid arthritis. High dose, daily use, we use it for anti-cancer medication. Okay, now we have the question here, multiple choice question. Which of the following condition would be contraindication for the receiving methotrexate? Select all that apply. I will start with the last one here. We have chronic liver disease, we have leukopenia, pregnancy, thrombocytopenia, and renal impairment less than more than 50 milliliter per minute. So let me know your answer in the description box. Okay, next medication, we have leflunomide Areva. Okay, leflunomide, Ariva, how this medication work, and we are going to bring the image for that. Leflunomide inhibit pyrimidine synthesis. Okay, and this will reduce proliferation of lymphocyte and modulate the inflammation. Efficacy of leflunomide very similar to the methotrexate. MTX stands for methotrexate. So leflunomide Ariva very similar to the methotrexate. Is there any side effect from the Ariva? Is popular side effect patient may suffer from nausea, vomiting, diarrhea, hair loss, bone marrow toxicity, liver toxicity. Leflunomide, if the patient suffers from liver disease, it's not allowed to use leflunomide. Okay, leflunomide teratogenic, it must not be used during pregnancy. So we have two main cases for contraindication. Number one, pregnancy, because this medication considered like teratogenic. Number two, liver disease. So if the patient suffers from liver disease, not allowed to use this medication. If the patient suffers from, if the patient maybe was a pregnant woman, it's not allowed to use leflunomide Ariva. Leflunomide, they found in the study of pharmacokinetic of leflunomide will be metabolized in the liver to the active metabolite called teriflunomide. Okay, teriflunomide is like active metabolite and responsible for the activity of leflunomide. So which of the following agent responsible, which of the following step responsible for activity of leflunomide will be the metabolism in the liver to the active metabolite called teriflunomide. Teriflunomide, okay, what happened with this active metabolism? They found teriflunomide increased blood pressure. This medication increased blood pressure in some patient. Therefore, we need to measure blood pressure to monitor blood pressure in this patient before the treatment, during treatment, and so on. And we need to monitor this one periodically, every 3 months, maybe every 6 months, every visit to the clinic, and we ask the patient, please monitor your blood pressure on a regular basis. So teriflunomide engage in increasing blood pressure. So we have three main issues here we need to remember. Leflunomide inhibit pyrimidine, leflunomide bone toxicity, leflunomide cause liver toxicity, teratogenic. Leflunomide has active metabolite. The active metabolite may increase blood pressure that require periodical monitoring of blood pressure for this patient. Okay, leflunomide, multiple choice question. Leflunomide would include, leflunomide monitoring would include all the following except, so here we are looking on the wrong answer. Okay, so pregnancy, complete blood count, serum alanine aminotransferase, liver disease or liver function, blood pressure, serum creatinine. So let me know your answer in the description on the chat box. Okay, so we discussed two medications. The first medication was methotrexate. The second medication was leflunomide Ariva. And you can see the name for the medication available, 10 milligram tablet Ariva. Okay, next group of medication we have hydroxychloroquine, Laquanil, and another medication monocycline monosine. Regarding the hydroxychloroquine, Laquanil, this medication used for mild rheumatoid arthritis cases, and this medication could be used like a combination therapy with other DMARD treatment. How this medication work? They found the hydroxychloroquine inhibit antigen-antibody reaction at the inflammation site. So we have maybe interaction between antigen-antibody and hydroxychloroquine inhibit antigen-antibody reaction. Safety profile, here what we have here for hydroxychloroquine, they said hydroxychloroquine lacks of the myelosuppressive effect. This is important. There's no myelosuppressive effect, lacks of the hepatotoxicity or renal toxicity. So this is the advantage for hydroxychloroquine. No myelosuppression effect, no hepatic toxicity, no renal toxicity. However, hydroxychloroquine may affect the eye. Hydroxychloroquine may cause retina toxicity. So for this reason here, if the patient take hydroxychloroquine, we recommend the patient to go to the ophthalmology clinic every 3 to 6 months or once per year for eye examination to be sure the retina is like healthy and there is no other like pathological changes in the retina due to the treatment with the hydroxychloroquine. So the question from this part here. Okay, the question from this part here regarding the hydroxychloroquine, which of the following medication may associated with the retinopathy in the treatment of the rheumatoid arthritis? So which medication used for rheumatoid arthritis and may associated with the retinal toxicity? Okay, which of the following correct about hydroxychloroquine? Hydroxychloroquine used for mild rheumatoid arthritis could be used in combination with other medication regarding DMARDs. Hydroxychloroquine lack of the myelosuppressive effect, hepatic toxicity, and renal toxicity. So we need to be familiar with all these, maybe highlight regarding the hydroxychloroquine. Okay, next medication here on the list we have minocycline, minocycline, and minocycline belong to the group of medication called antibiotics. So here we talk about antibiotic, and we cover antibiotics in the maybe several recorded videos, and recommend you if you need more information about minocycline. Minocycline belong to the tetracycline groups. Okay, how this medication work? Minocycline inhibit metalloproteinases enzyme, and this enzyme involve in maybe or induce cartilage damage. So our medication here inhibit metalloproteinase enzyme, and this enzyme responsible for cartilage damage. Okay, indication again for mild rheumatoid arthritis and without poor prognostic features. So again, if you remember that if the patients are from high risk of rheumatoid arthritis with the poor prognostic features, the indication there, when you have poor prognostic and high activity of the disease, remember the drug of choice will be tumor necrosis factors such as infliximab, such as adalimumab, Humira, and Enbrel. This medication, minocycline, available like 100 and 200 milligram. Here we try to remind us what is metalloproteinases. Fibroblast produce matrix metalloproteinases, and this enzyme ACEs here responsible for degradation of bone matrix and produce pro-inflammatory cytokines. Okay, next group of medication we have sulfasalazine. Sulfasalazine, zilofidine, and the brand name. How this medication works: when you prescribe sulfasalazine to your patient, sulfasalazine will arrive to the colon, and in the colon we have bacteria, and this bacteria will cleave the sulfasalazine to two compounds, sulfapyridine and 5-amino salicylic acid. Again, when you take this medication orally, this medication will move from the oral esophagus to the stomach, intestine. Nothing happened to this medication until this medication arrives to the colon. In the colon, we have bacteria, we have flora there, and this bacteria is responsible for metabolism or cleavage of the sulfasalazine to two substances. The first one called sulfapyridine. Sulfapyridine responsible for the activity against the rheumatoid arthritis, sulfapyridine. Another component, another part from this metabolism will be 5-amino salicylic acid, ASA, and this one may be responsible for that benefit on patient with the irritable bowel syndrome. So here we have important concept to discuss here regarding sulfasalazine. Sulfasalazine is the medication used to treat rheumatoid arthritis and irritable bowel syndrome. Which of the following metabolites responsible for the rheumatoid arthritis? So please remember we have sulfapyridine. Okay, this one number one mechanism. Number two, another mechanism they found the sulfasalazine considered like immunomodulator and anti-inflammatory drugs. Uh, Expected onset of action when you prescribe sulfasalazine to your patient. This medication take 2 months at least to start seeing the effect as anti-rheumatic maybe characteristic. So here we have long term. We need like 2 months, like 60 days to see the effect on the sulfasalazine. Okay, sulfa. So sulfa in general, when you talk about sulfa, this is the second most popular medication responsible for allergy. So please remember sulfa because they're like second medication responsible for drug allergy. Okay, so the common things here, patient may suffer from nausea, vomiting, anorexia, diarrhea, but here we have skin rash, allergy, serum sickness-like reaction. Here the sulfasalazine may inhibit the bone and cause leukopenia, alopecia, stomatitis, elevated liver enzyme, may color the urine, may color the skin, and the patient suffer from yellow, orange urine and the skin. So the discoloration here, you can see it, the discoloration and the urine and discoloration of the skin regarding the treatment with the sulfasalazine. We need or sulfasalazine or sulfasalazine. We need to recommend the patient, don't worry if you see the skin or the urine turn to the yellow or orange. This is due to the treatment with the sulfasalazine. Okay, so this slide here shows us a table about the medication. We discussed methotrexate, leflunomide, hydroxychloroquine, plaquenil, sulfasalazine. We discussed the, for example, we are going to discuss less used medication. We have very important medication here. We have tofacitinib, exalgens. For example, we use it also. So we need you to be familiar with the brand name for some medication, plaquenil for hydroxychloroquine, Ariva for leflunomide, Trixal for methotrexate, and so on. Again, do you need to remember all these? Could be, it's important for your clinical practice. If you are in the clinical practice, we need to remember we prescribe methotrexate for RA once a week, hydroxychloroquine once daily, leflunomide once daily, so you can see the difference here, and the same situation apply. Shall we take it like oral or intramuscular or IV? We need to look all these data there. Okay, what about the monitoring adverse effect for the medications here for every medication for NSAID and salicylate, cortisone, hydroxychloroquine. Okay, you can see the ophthalmoscopy annually for the hydroxychloroquine. What about methotrexate? We have the myelosuppression, hepatic cirrhosis, pulmonary infiltration, stomatitis, so we have it there. Leflunomide, hepatitis, distress, GI distress, and alopecia, all these important side effects. Okay, which of the following drug is used to treat rheumatoid arthritis with a special precaution to guard against the development of retinopathy? So medication used for RA, but this medication may cause retinopathy. We have methotrexate, hydroxychloroquine, and infliximab celecoxib. Okay, I will repeat the question again. Which of the following drugs is used for treatment of rheumatoid arthritis with special precaution to guard against the development of retinopathy? So here we ask about retinopathy. So which of the following maybe treatment could associated with the retinopathy, risk of retinopathy? Methotrexate, hydroxychloroquine, infliximab, and celecoxib. Let me know your answer in the chat box or in the description or communication in the comments. Okay. Here we have 3 medication. We are going to speak about JAK inhibitor, and this is considered like second line treatment, and this belongs to the second line treatment non-biological factors. We have group of medication called JAK kinase, as you can see it here, JAK kinase inhibitor, and you can see that JAK means Janus kinase, and this is type of enzyme belong to the tyrosine kinase. This medication prescribed orally, and we have 3 group of medication. We are going to discuss the name with you. This medication or JAK inhibitor considered like JAK inhibitor, oral synthetic small molecules, can be used monotherapy, can we use it like combination treatment. So we have two options there. We use it alone or use combination with a methotrexate or any other biological factors. Okay, so what we have so far regarding the second line therapy for the second line therapy for non-biological DMARDs, we have JAK inhibitor, we have three medication, we have tofacitinib, we have baricitinib, then we have ubitacitinib, citinib or citinib, tofacitinib, baricitinib, and ubitacitinib. So here we talk about the drug name, the brand name, Xeljanz, Rinvoq, and Olmiant. So three medication here in the clinical practice. Do you need to take any precaution, black box warning for this medication? They said yes, very important. This medication may cause or may predispose patient to the infections. This medication may, if the patient suffers from tuberculosis, this medication may reactivate the tuberculosis. This medication increased risk of malignancy. This medication increased risk of all causes mortality. This medication may increase risk of thrombosis, and we need to avoid live vaccine in this patient. So we have in the black box warning here, we need to review the black box warning for the patient. If I click on the what we have here, okay, what we have here, you can see the Xeljanz, tofacitinib, and I will look on the, me and you together, look on the what happened there with the Xeljanz here. It's like approved by FDA 2012, tablets available there, extended release tablet, increased risk of infections, could be bacterial, fungal, or viral infection, a high rate of all cause of mortality, you can see there. What else? Malignancy, increased risk of malignancies in patient treated, and then we have high rate of the myocardial infarction due to the deep vein thrombosis. So we have the deep vein thrombosis here. Okay, so here again, we need to remember these three medication. Okay, we need to remember these three medication belong to the JAK inhibitor. We have Xeljanz, Olmiant, and then we have Rinvoq, tofacitinib, and baricitinib, and ubitacitinib. This medication considered like JAK inhibitors, JAK enzyme inhibitor. This is number one. Number two, non-biological, second line treatment for rheumatoid arthritis. And what else? We need to be maybe monitor the patient. We have black box warning, BPW, stand for risk, increased risk of infection, reactivate tuberculosis, increased risk of malignancies, increased risk of mortality, increased risk of thrombosis. Okay, so we're done with the non-biological factors. We're moving to the biological, second line. Again, biological factors, second line treatment, not the first line treatment. We have biological DMARD for rheumatoid arthritis. Here what we have, we are talking about tumor necrosis factor alpha, tumor necrosis factor alpha inhibitor. I stands for inhibitor, tumor necrosis factor alpha inhibitor here. Okay, then the first one we have Humira, adalimumab, Cimzia, citrulumab, Enbrel, etanercept. Then we have Simponi, golimumab, Remicade, infliximab. So we need to be familiar with this name: adalimumab, Cimzia, Enbrel, Simponi, Remicade. Okay, so this is a tumor necrosis factor alpha inhibitor. We can use biological factors not belong to the tumor necrosis. We call this one non-tumor necrosis factors. And if you remember, we have different category there. So this one, abatacept, this work on the T cells, inhibit T cells, abatacept. Then we have rituximab, mainly work on the B cells, inhibit the activation of B cells. Then we have anakinra. Anakinra work inhibit interleukin 1, Kineret. Then we have Actemra, tocilizumab work on inhibition of interleukin 6. So you can see what we have here regarding the maybe category classification of biological factors. We need to remember the category here. A tumor necrosis factor, we have adalimumab, satralizumab, etanercept, golizumab, infliximab. Non-tumor necrosis biological factor, we have abatacept, rituximab, tocilizumab, and anakinra. Okay, biological factors, any advantages, characteristic? They said biological factors may be effective when other medication have not been approved to be effective. However, effective medication, this medication more expensive, thousands, sometimes of the dollar. No laboratory monitoring for toxicity, for example. Here we need to look on what we have here for vaccination. We have to be careful. Tuberculosis, we test that. Again, we need to test the patient for tuberculosis. We have different approach here for the tuberculosis. For all patients should be done before treatment, prior to treatment with this biological factors. Patient with significant tuberculosis may not be good candidate for the treatment. So if the patient suffers from tuberculosis, active tuberculosis, is not allowed to prescribe biological factors. If infection developed during treatment, we need to stop the medication temporarily until the patient cured from the tuberculosis. We strongly recommend no live vaccination. It's very important here. Again, this table here summarizes the information for biological factors and TNF-alpha and non-TNF-alpha, infliximab, etanercept, adalimumab, satralizumab, golimumab, abatacept, rituximab, anakinra, and tocilizumab. How this medication prescribed, IV, subcutaneous, so on. How often we prescribe this medication? Every 4 weeks, for example, here. Then for rituximab in 14 days. Once daily anakinra. So anakinra, 1 injection every day. Tocilizumab, 1 injection every 4 weeks. So we have all these maybe characteristic of the medication belong to the biological factor. So this table here present biological factors, could be TNF-alpha or non-TNF-alpha. Okay, some characteristic, usual doses here we need to remember that, for example, TNF-alpha inhibitor here, we have etanercept, we have infliximab, we have adalimumab, and all these TNF-alpha. We need to remember the risk of infections here, risk of infections, most of them, risk of malignancy, the same. Okay, all these medication here we need to take in consideration. Okay, infliximab reduce its anti-rheumatic effect by direct inhibition of cyclic AMP, direct, maybe selective COX-2 inhibitor, enhanced prostaglandin synthesis, enhancement of leukotriene, reduce circulation of tumor necrosis factor alpha, or inhibition of production autoantibody. So let me know your answer in the comments. Okay, please remember here infliximab, you need to go to the previous slide to figure out how this medication works. Okay, last group of medication regarding the rheumatoid arthritis, we have non-TNF biological factors. Abatacept prevent T-cell activation. Rituximab induce lysis and doublets of the B cells. Anakinra considered like interleukin 1 antagonist. Tocilizumab interleukin 6 antagonist. So from this slide here, give me medication prevent T-cell activation, abatacept. With this medication inhibit B cells, we have rituximab. With this medication inhibit interleukin activation of interleukin 1, we have anakinra, and so on. Abatacept, more information. Abatacept work on T cells here, and we have the information about abatacept binding to the CD80, CD86, and preventing on the receptor antigen presenting cells, inhibit interaction between the T cells and ABC cells, and this will lead to the prevent T cell activation. So the main action of abatacept prevent T cell activation. How? This will prevent binding between the CD80, 86 to the another part of the maybe of the T cells and ABC cells. Regarding rituximab monoclonal antibody, we know that rituximab affect the CD20 on the B cells, and when the binding to the CD20 on the B cells, this will lead to the death of B cells. Okay, now we try to bring some diagram as explanation for us what happened. We know that we have APC, antigen presenting cells. Okay, this will lead to the activation of T cells. The T cells will activate B cells, and this will activate also macrophage. So this is a normal physiology function in a human body. And what happened there? Macrophage will activate interleukin 6, interleukin 1, tumor necrosis factor alpha. Okay, and this will cause inflammation. So activation of macrophage, and we have this interleukin and tumor necrosis, B cells. All these lead to the inflammation of the synovium. Okay, activation of the synovium, inflammation here. We have inflammation now. And we have activation of immune system. We have complement activation. Okay, for example, here you can see we can use rituximab that inhibit B cells. What else? We can use abatacept that inhibit T cells as a medication. Okay, we can use some medication that inhibit tumor necrosis factor alpha. We have etanercept, adalimumab, infliximab, and other medication. This is the most popular one, the green one. Then we have other medication work on interleukin 1, the red background, and you can see the medication here, anakinra. Anakinra inhibit the interleukin 1, black interleukin 1. What about interleukin 6? Interleukin 6 we have tocilizumab. So tocilizumab inhibit interleukin 6. And this slide here maybe represents the site of action of each medication and the mechanism of action. Give me medication, inhibit T cell activation. We have abatacept. Give me medication, inhibit action of B cells. We have rituximab. Give me medication, inhibit interleukin 1. We have anakinra. Give me medication, inhibit interleukin 6. We have tocilizumab. Which of the following medication belong to the biological factor by inhibiting tumor necrosis factor? We have tocilizumab, infliximab, and adalimumab. Okay, this slide here present the medication drugs used for rheumatoid arthritis, present the site of action of this drug, and present the mechanism of action of these drugs. Okay, regarding the abatacept mechanism of action, you can see we have T cell, and on the T cell we have CD28 attached to the T cell, and at the same time we have T cell receptor here. We have CD828, and on the ABC antigen presenting cells we have MCH, stand for the, if you can see it here, stand for the major histocompatibility complex, and we have interaction between these when we have activation. So what we have here, when the antigen presenting cell activated, you can see here this is a normal response. So the CD28 bind to the CD86. This is a normal response, normal physiological response. When you prescribe abatacept to the patient, okay, so this is the abatacept, now we prescribe it. Okay, abatacept here. When you prescribe abatacept bind to the CD86. So you can see here abatacept binding to the CD86 and prevent binding this segment here to the CD28. So you can see here they prevent binding and activate T cells. So abatacept working on the T cells by bind to the CD86 and prevent binding to the CD28, and this will prevent, you can see here abatacept binding to the CD86 receptor, and this will lead to the inhibit interaction between the ABC antigen presenting cell and T cell and prevent T cell activation, and this will lead to the inhibit and inflammatory process. And we have the abatacept here. You can see it like pre-filled syringes. Prescribe it to the patient. Rituximab. Rituximab work on the monoclonal antibody from the map here, monoclonal antibody, and targeted the CD20 antigen or antigen on the B cells, binding to the B cells, lead to the B cells lysis and death, and this will lead to the depletion of peripheral B cells. Again, we have some maybe details about non-biological DMARDs, mechanism of action. Abatacept prevent T cells, tocitinib, acternab prevent maybe considered like interleukin 6 antagonist, anakinra interleukin 1 antagonist, rituximab bind to the CD20 and the B cells and lead to the depletion of B cells. Do you need to remember something? Yes, we need to avoid live vaccine, and most of the medication here, live vaccine may cause serious side effects, serious infections. Yes, so we need to take all these on consideration. Okay, pharmacotherapy, we can use a glucocorticoid as a sympathetic maybe treatment. We have methylprednisolone, we have prednisolone. We remember that during pregnancy, drug of choice will be prednisone. We remember that, and we can use it as a bridge therapy. What that means with the bridge therapy, when you prescribe the DMARD to your patient, this will take at least like a few weeks or like 2 months sometimes to start working. Therefore, we use a corticosteroid to maybe to see the quick effect of this medication. Then we can remove this medication gradually in order to avoid the suppression of the axis, hypothalamus pituitary adrenal gland. And they try to remind us this medication may cause increased risk of myopathy, infectious disease, osteonecrosis. Okay, non-steroidal. Okay, non-steroidal we can use it, but we need to remember this one only to improve symptoms. There is no alteration in the disease. It could be like adjunct therapy to relieve the symptoms and reduce stiffness in the morning for the patient here. Okay, the question here, in order to reduce toxicity of methotrexate, concomitant administration with what vitamin is recommended? So you place the patient on methotrexate, the patient diagnosed with RA, and you place the patient on methotrexate. Which of the following you recommend to use concomitantly with the methotrexate to reduce risk of toxicity? Folic acid, thiamine, ascorbic acid, pyridoxine, or riboflavin. So let me know your answer in the comment. Okay, the last one here, like a reminder, comparison between what we have there, comparison between NSAID, for example, and DMARD, comparison between methotrexate and NSAID. Okay, the DMARD slow progression of the disease, DMARD arrest progression of the disease. Okay, we have question mark here, it's not correct. It does not arrest slow progression, prevent formation of new deformity, used for chronic cases when the deformity exists. However, if you move to the what we have there, okay, so the NSAID provide rapid improve of symptoms, no effect on the progression of the disease, cannot stop the inflammation or formation deformity, used in acute cases only for the pain and inflammation. A quick comparison, but here we need to modify this arrest. It's not arrest, slow progression of the disease. Here we need to type slow progression of the disease. Okay, which of the following is the reason that DMARD that are preferred over non-DMARD for the BA management or for the rheumatoid arthritis management? Okay, so DMARD have fewer adverse effects compared with non-DMARD. DMARD less effective than non-DMARD. DMARD may reduce or prevent joint damage and preserve joint function. DMARD do not require those laboratory monitoring. So which one apply? And let me know your answer in the comment box. Okay, cost of therapy is very important. If the patient may be covered by the insurance or not, you can see it here. what we have, okay, for methotrexate and so on. Okay, this slide here presents the cost of therapy that need to be taken in consideration when you prescribe the medication to your patient. For example, here, if I'm prescribing methotrexate to the patient, I will go back a little bit. Okay, methotrexate, you can see here the methotrexate cost like average wholesale for 20 tablet here like $78. Annual cost for the methotrexate 600. Leflunomide a little bit more expensive for per 30 tablet per month than per year. Okay, if I scroll down a little bit, look on the, for example, infliximab. We look on the adalimumab, etanercept, all these medication here, rituximab, abtacept, for example, you can see thousands of dollars per year. It costs your patient here, it's maybe a range from $11,000 to the $34,000 per year. It's like very expensive medication. It's very important to be covered by the insurance company. Okay, by clicking on the link available on the slide, you can see here American College of Rheumatology guideline for treatment of rheumatoid arthritis coming from the American College of Rheumatology. They have a lot of detail there. So I recommend you to go through this DMARD treatment, for example. And we have a lot of details there and data about disease activity, remission. You can see the category for methotrexate, for example, here. Then we have a group of medication, TNF-alpha, biological factor, non-biological factors, for example. And they have different approach. You can see here the patient, most people in your situation would want to the recommended course of action, clinician here. Okay, so we have different approach, depends on the strong recommendation and so on. So I recommend you to review this article at your own time. Okay, this will conclude our lecture for today, and we cover the rheumatoid arthritis. We spoke about the definition, the etiology, pathophysiology, characteristic, clinical and signs and symptoms of rheumatoid arthritis. Then we spoke about the diagnosis of rheumatoid arthritis. Another issue here, the management of rheumatoid arthritis regarding the non-pharmacological approach or pharmacological approach. Also, we discussed the medication name. We discussed DMARD. We have DMARD. Under the DMARD umbrella, we have biological factor, non-biological factors. Under the biological factors, we discuss which one belong to the tumor necrosis alpha inhibitor or non-tumor necrosis alpha inhibitor, which one affect B cells, which one affect the T cells, which medication affect the interleukin 1, which medication affect interleukin 6, and so on. We discuss adverse drug reaction regarding, for example, hepatotoxicity, retina toxicity. We discuss for example, the rescue therapy regarding the methotrexate treatment. We have the rescue therapy called lacofarin, and this medication used to prevent any complication coming from the methotrexate. This will conclude our lecture, and thank you for your watching, and have a great day. The next topic will be osteoarthritis.